Okay, so let me ask you a question. When you have an old man which is present with sudden loss of vision with only light perception, before everything, before doing ultrasound, before doing a fluorescein angiography, what will you think of? What will be your differential diagnosis? So I will think, yes, I agree that it could be an anterior ischemic optic neuropathy, or it could be a central retinal artery occlusion. I agree as well. So giant cell arthritis, that's right. So this patient who has a vision of light PL, and you did the fluorescein angiography and show this picture. So what does this picture show? This picture show normal filling of the choroid, like in the we don't have it, we don't know if this is nasal or temporal, but let's say that this is the nasal, for example. So there is normal choroidal filling, and there is normal venous filling, but here there are arterial non-filling. The arteries here are non-filling. So what could it be? And here is on the other side, we can see that there is area of total choroidal non-filling. There is absent choroidal filling. So this will exclude the central retinal artery occlusion, as the central retinal artery, this is a branch or this will not cause absence of the choroidal filling, as the choroid is supplied from the ciliary circulation, not from the retinal circulation. Again, Dr. Ismail, ophthalmic artery occlusion ophthalmic artery occlusion will not cause selectively absent choroidal filling at one side and normal choroidal filling at the other side, because all ciliary branches will be occluded. So again, this is not an option. Well, branch retinal artery occlusion is unlikely to cause only PL perception or only light perception. And again, if there is a branch retinal artery occlusion, this is a retinal disease, or this is a retinal blood vessel. Why would it cause absent choroidal filling? So you have just to separate between the choroidal circulation and the retinal circulation. Affection of the retinal artery, or like the central or the branch, this will affect the retinal circulation. But here is the choroidal. There is silent choroid, no choroidal filling here. And just to have a clue about this high or this very old man, this very old man of 80-year-old, there is an important disease that characterized by sudden loss of vision, which is causing a severe loss of vision in very old age population. No, Dr. Moose, no, it is not retinal detachment. Retina is on here. No, again, not ocular ischemic. Yes, it is the giant cell arthritis. So actually, when you are seeing this patient, or you are seeing a patient with old age, with presence of sudden loss of vision and only light perception, uh, you are in case of let me just exclude your that options you mentioned. Retinal detachment will be evident clinically and by ultrasound, so we don't do fluorescein for retinal detachment. Ocular ischemic syndrome will show attenuated arteries and dilated veins with presence of multiple hemorrhages, cotton wool spots, the picture of retinopathy that we all know, and doesn't presence with choroidal non-filling. Again, I'm stressing on that. So in this case, we are suspecting two diseases. Mainly it is, which is the two derivatives of anterior ischemic optic neuropathy. So this can be non-arthritic or the arthritic one. Both of them will cause sudden loss of vision, and both of them will be at older age group, but typically the arthritic form will be at more older age group, like about 80 years old in case of or very old population. and also the arthritic will present with more drastically loss of vision than that of the non-arthritic. So now we have different options. We don't need CT chest and abdomen. This will not be useful for any one of them. Magnetic resonance also of the head and the orbit will not be useful for any of one. So how would you, what will be the next step? Not the diagnostic step, but will be the next step. The ASR will be helpful to suggest the arthritic ischemic optic neuropathy or giant cell arthritis. On the other hand, the carotid Doppler ultrasound will be helpful for diagnosis of the non-arthritic ischemic optic neuropathy. So again, here we come to the question, could it be arthritic or non-arthritic? So how can we differentiate from the fluorescein angiography? I have mentioned this in the neuro lecture, but let me repeat it. If we have here, let me just erase that. If we have here an optic nerve and here are the major arcades, and there is what's called the ciliary circulation, which are supplying the choroid and the outer 1/3 of the retina. This choroidal circulation is consisting of the long posterior ciliary arteries and short posterior ciliary arteries. So there is two long posterior ciliary arteries, one medial and one lateral. And in case of giant cell arthritis, what happens is that there is vasculitis. This is a vasculitis disease. So there will be vasculitis affecting the long posterior ciliary arteries. And what happens after that? There will be occlusion of the posterior ciliary arteries. So suppose that this artery is occluded by the vasculitis of giant cell arthritis. And we know that the choroid is filling in the early stage of the fluorescein angiography. So in case of the arthritic, the anterior ischemic optic neuropathy, there will be evidence of posterior ciliary artery occlusion by massive defect of the choroidal filling. The choroid will be non-filling. At the area where the occluded vessel or the posterior ciliary artery is occluded. So this is what will happen in the giant cell arthritis or in arthritic ischemic optic neuropathy. This is very rare to happen in the non-arthritic ischemic optic neuropathy. So that the fluorescein angiography will be very helpful in differentiating between the giant cell arthritis and non-arthritic ischemic optic neuropathy. But what happened in the non-arthritic? In the non-arthritic, what happens is some sort of vasculopathy or ischemia. This ischemia affecting the para-optic branches of the short posterior ciliary arteries. There are an array of short posterior ciliary arteries that are distributed around the circumference of the optic disc. These short posterior ciliary arteries are giving branches to the optic disc. They are called para-optic branches. These para-optic branches undergo ischemia. So what happens when these blood vessels or these para-optic branches undergo ischemia? This will cause delayed optic disc filling. So again, there will be delayed optic disc filling and will be normal choroidal circulation. So this will be the differentiating feature. This means that there is a vasculopathy affecting the para-optic branches of the short posterior ciliary arteries after they branch from the choroidal branches rather than after they branch from the short posterior ciliary artery themselves. So this means that in conclusion, the giant cell arthritis will cause defective choroidal filling that appear in the early stages. On the other hand, the non-arthritic ischemic optic neuropathy will show delayed optic disc filling and will show normal choroidal filling. So since this patient is old and has only vision of light perception with defective choroidal filling, so we will go for the ESR as one of the important rapid tests in order to suggest that the patient has a giant cell arthritis. So let's move now to the next question. Oh, by the way, just for fun, I would like to present to you this photo. This is the original photo that the ICO brought in the exam. You will not find this photo anywhere in any of the past papers that you have, because actually I brought this photo from the internet, from Google search. So you can see that the ICO bring in the exam not real cases, but or they are just Google the images and just present to you in the exam. And by the way, this paper or this photo was published in one of the papers, and it was diagnosed as a giant cell arteritis. So just to let you know how those of the ICO examiner put the exam. Yeah, this is the same photo itself, the same exactly. Okay, move to the next one.